Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi, everyone. Welcome to another episode of the Egg Whisperer Show. I'm so excited to have Dr. Meredith Provost on today's show. Hi, Dr. Provost.
Hi, Dr. Amy. How are you?
Call me Amy. I just
Okay.
wanted to say Dr. Provost. It's a beautiful name. I'm kind of jealous of people who don't have a bazillion letters in their last name. That's why I just say it. So thank you for joining us. Today's topic, and you are truly the expert, is this. This is the topic. The best health, exercise, and weight recommendations for your fertility. So for the listeners, I just want to tell you a little bit about Dr. Meredith Provost. She's an all-star. She had received her undergraduate degree at North Carolina State University in biochemistry, medical school at McMaster University. She even has a PhD, folks, from University of Cambridge in history and philosophy of science. And she just was too bored, apparently, just with that. So then she went on and did a residency in OBGYN at University of Arizona, a fellowship at Duke University. I've heard of that place. I heard you have to be really smart to get in. And she has clinical interests very similar to mine. She's a baby maker, after all, in infertility, endometriosis, PCOS, recurrent pregnancy loss, and fertility preservation. And her list of awards is lengthy, and you can see them on her website. So Meredith, where can people find you? Where can they learn more about you? Tell us about your practice.
Yeah, so I am in Indianapolis, Indiana. We're in a suburb called Carmel on the north side of the city, but it's Indiana Fertility Institute, and we're at fertilityindy.com.
Awesome. And then you're active on social media as well. Where can people find you on social media?
Yeah, so I'm at Meredith Provost MD on
Great.
Instagram, and maybe you'll see me on Twitter coming here soon, but not quite yet.
I love Twitter. Twitter is fun because you get to hear the latest and greatest from different companies. You learn what they're doing. So I'm glad I'll be seeing you on Twitter soon. So tell us about what made you go into medicine, first of all.
So I had a little bit of an unconventional path, I would say, going into medicine. It would seem like I was headed that way because I was a biochemistry major, kind of a classic pre-med major in undergrad, but I was actually in the first year college for 3 years. I just love learning. I think I just have a passion for learning. But after kind of deciding on biochemistry, I thought I was heading directly to medical school. I applied to medical school, had gotten in, and was really planning on graduating and going straight to medical school in the US. And I ended up applying initially for a Rhodes Scholarship. I was a Rhodes finalist. And then Bill Gates started a scholarship over at Cambridge. And I applied for a master's degree in the history and philosophy of science and medicine, deferred medical school for a year, and then ended up staying and doing my PhD because I was just having such an amazing time and learning so much. So realized in that I missed working directly with people. A lifetime of research really just wasn't the career path for me. But I eventually applied and went back to a different medical school. And that kind of went from there.
That's awesome. And what led you to the field of women's health, OBGYN, and then ultimately being a fertility doctor?
Yeah, so I've always loved working with women. I joked when I was in medical school that it really is often the women that are involved in facilitating medical career care for themselves and for their spouses, that men are generally coming because the woman in their life, whether it's their child, their wife, their mother, has told them that they need to see a specialist. So I've always really loved working with women. And that was kind of always what I planned to do, but I didn't know in what way until I was in medical school. And as a first year medical student, I did just a rotation and observership at a reproductive endocrinology office. And up until that point in my life, I'd always kind of been all over the place on exactly what I wanted to do. But I remember coming home and calling my parents and be like, this is it. This is definitely what I want to be. I just loved the patients. I loved being able to emotionally care for them. I loved that it brought in the biochemistry, and my PhD had been working with Watson and Crick in DNA. So I was bringing in all of those things that I'd been teaching about, at Cambridge, where Louise Brown had, been conceived in 1978. And it just brought everything together for me. And it was just that first day, it was love at first sight. It took 12 years later till I could actually practice. But yeah, from that day on, I knew.
Yeah, that's awesome. And I see there's a picture of a basketball player behind you, and you're also an athlete. So tell us about your athletic career as well.
Yeah, so I played volleyball at NC State. I was on the volleyball team as team captain for 2 years, MVP my senior year. So that was kind of my life for a lot of growing up. I also played basketball in high school, ran track in high school as well. So I really would have defined myself almost as an athlete first and a scholar kind of evenly to that until that point. When I was at Cambridge, I played basketball for Cambridge, and I actually boxed for a little while, which is a unknown fact about me that you're getting here.
So you are the perfect expert for this talk today. So thank you. So I want you to talk to our listeners a little bit behind the science behind weight and fertility. What do scientists know right now about it?
So we know that without a doubt, weight can impact fertility outcomes. The way that I like to describe it to patients is that our weight affects how our brain talks to our ovaries. Weight impacts the messages that our brains normally send to our ovaries in order to get us to ovulate every month. And that's the simplest way, I think, to think about it. It can go a lot more deep from there, but yeah, it just affects the way that our bodies communicate.
That's really a great way of describing it. And then in what way would your weight impact your fertility if, let's say, you had a higher BMI or lower BMI? Can you talk more specifically about those different scenarios?
Right. So for patients with higher BMIs, the way I like to talk about it is that fat, from my standpoint as a reproductive endocrinologist, fat isn't about how your genes fit or, what you're looking at when you look in the mirror. Fat is a hormonally active tissue. And fat cells make estrogen. And estrogen is the hormone that tells our brains, it's the same hormone that our ovaries make. And so if we have a lot of fat cells in our body, they're telling our brains that we really don't need to send a message to our ovaries because we have enough. And so what it does is it keeps our brain sometimes from sending messages to our ovaries to get ourselves to ovulate each month. So it can have an impact on your ability to get pregnant from that way. For patients that are underweight, it's kind of the opposite problems. The problem for patients that are underweight is starting at the level of their brain where their brain it's not sending the message to their ovaries because it is stressed out and thinks that it's starved. And so that causes kind of an opposite response. There's all kinds of other hormones like cortisol and things that can get involved, but it keeps that brain from sending messages to our ovaries, which is involved in our fertility.
And what about for men? Do men have the similar, I joke and say men's brains are never talking to their balls. Ha ha ha. I should have a laugh track. Sorry guys, I'm not trying to shame you or you know what I'm saying. But what's going on for men and with the same types of scenarios, overweight, underweight?
Yeah. Interestingly, it's actually estrogen in men that sends that same feedback message to the brain. So when men have higher fat cells and more estrogen production, they actually produce less testosterone as well. So that can affect their sperm production, but it can also affect their sex drive, just making lower sex drive, and that certainly can affect fertility. And then the other thing that can happen with men who are obese is that the testicles are actually outside of our body for a reason. They're supposed to be at a slightly lower temperature than the rest of our body. But if we have a lot of adipose tissue, that can raise the temperature of the testes and also affect sperm production in that way as well.
Yeah. And then how do you calculate? What's the number that we use? You hear a lot about the BMI, and what does that mean to you as far as BMI?
Yeah. So we when we talk about medicine, we're doing research studies, we talk about BMI a lot, and it's a function of our height over our weight over our height. So it's kilograms per meter squared is the way that you calculate. And there's tons of online calculators that you can use if you don't work in the metric system. It's easy to figure out. But yeah, we basically look at that BMI, which is, it just normalizes height and weight across different people depending on, and you can kind of look at whether or not you're obese based on that scale.
Yeah. I think it's probably the best way to do things. And certainly there are other ways. Do you think that it's the best indicator?
Yeah, there can be certain challenges with it. I mean, I still remember as a D1 athlete, I at one point was looking at military scholarships and had hit the obese scale. And I don't know, you can see I'm not overweight, but I had so much muscle mass. So, a lot of athletes that have a ton of muscle mass that weighs more than fat, so they can have higher BMIs despite the fact that they are, in great shape, and it probably is not affecting their fertility. It's the best that we have, but you get a lot more wiggle room if you're taller. If you're shorter, you get less wiggle room because of the way it's calculated. So it's not the perfect metric. I think it gives us some information, but just like anything, where we carry our fat can be important, as much as just a number.
Right. And I'm sure you get this question all the time, is what is the best diet? I probably get that question emailed to me, at least 1 to 3 times a day. Is like, what diet should I follow? So how do you counsel your patients knowing everything that you know?
I do. And I think it's a challenge. I think the best diet is something that you can maintain. I always say fertility is a marathon, not a race. So if whatever diet you're doing, you can only do for a week, that is not going to work. This needs to be something that you can do for a long period of time. My main rule of thumb is eat real food. I think if you are eating actual food that's, fruits, vegetables, meats, that has not been processed, it's going to be hard to go really wrong with a diet. There's all kinds of interesting things. I mean, for some of my PCOS patients, I do have some interest in intermittent fasting. There's a great book by Jason Fung on that called The Obesity Code. I think you can get into really restrictive diets that just set people up for binge eating, though. So you have to be a little bit careful with those. So yeah, I think to me, for my patients, the main thing is eating meals and eating real food when they are eating meals.
That's great advice. And if weight is a factor with your fertility, what kind of advice do you give your patients?
One is to look at their diet and look at how much processed foods they're eating. I think often even things like diet soda we think is great, but it does have an impact on your insulin, and it can overall cause weight gain. We know that for patients. So assessing that, seeing a nutritionist can be a great option. And having an accountability group. There's so many creative ways to have accountability groups these days with the internet. There's all kinds of online motivational groups. I think just with any change that you're trying to make, having some sort of accountability really helps make changes.
Yeah, I mean, sometimes I ask patients, update me the first of every month, give me an update, tell me where you're at, we have this goal, and I become their accountability partner. And so that's really a good point that you brought up. It's just nice to have that person, for sure. Mm-hmm. So I get a ton of questions about exercise. How much can I do? How much weight can I lift? And I want to go through the different treatment scenarios and see what you think are the best recommendations for our patients and what you tell your patients. So what exercises can a woman do during her IUI treatment cycle? And when should she stop, if you think she should stop?
Yeah, I mean, I don't really tell patients to stop. I think if they're exercising, that's great. If the woman has a problem with exercise, if she's over exercising, that's a different story. The rule of thumb is if you can't take a day off of exercise, or you think that taking a couple of days of exercise off is something that you cannot do, then there may be some pathology there. If you're not a professional athlete, if you're not a professional athlete and you can't take a day or two off of rest, then that may be a sign that you're exercising too much. But for everybody else that's out there running a mile or two and lifting some weights on regular, I think that it's fine to continue exercising. I think it's a great way to release stress. We take a lot of our other coping mechanisms away and off the table when we're doing fertility treatment. So any healthy ways we can have, then that's a good thing to continue.
Yeah, I mean, I think that's a really good, very important point for people to hear, is that as soon as you try and get pregnant, you think that you have to stop all the things that you enjoy, including exercise, and that can potentially be detrimental for some people.
I say you're pregnant, you're not broken.
Yeah,
if your body works,
right.
Use it.
Exactly right. So what about during an egg freezing or an IVF cycle? What recommendations do you have around exercise at that point?
Yeah, the only really time I have recommendations around restriction of activity, as long as it's reasonable activity, is when the ovaries are big and we want to protect them. So that the only situation that would really be in is in a fresh IVF cycle, or when we're actually retrieving eggs. Usually in that second half of the IVF cycle, patients start to feel uncomfortable, the ovaries get large, you can start getting risk of ovarian torsion and just things like that. So I usually tell patients in that window of time to really take it easy. Still walking is fine. So you can get outside and move, but you really have to listen to your body at that time.
Perfect. And then what about after a transfer or leading up to a transfer and after the transfer and an early pregnancy? Sorry, I gave you 3 questions.
Oh, I don't really restrict activity for those patients. I kind of say, I always joke and I say, don't take up running a marathon if you haven't, and don't go to the bar and ride the mechanical bull. I just always say that to patients. I'm I've never even been to a bar with one of those, but I've always said that.
I might have.
So, don't take up some sort of crazy activity that you've never done before. But if something's in the wheelhouse of what you do every day, then continue that.
I love that. Okay. And then do you have a goal BMI for your patients? Like, is there when you assess them at the new patient visit, what do you bring up with them as far as what your goal is for them to achieve the best treatment outcome?
I mean, when we look at IVF outcomes, we definitely see that patients of a normal BMI, or even with IVF, even a lower BMI, they do better when we look at just straight IVF outcomes and miscarriage rates across the board. The trick is that as we go up in those BMI categories and get to heavier weights, we see a decline probably from normal up to the highest weights of about 10% reduction in IVF success rates. But even at the highest BMIs, our success rates are still higher than we see in some young normal weight patients who have other diagnoses like diminished ovarian reserve. So we're really stuck in this hard place with how far we go in terms of recommending that patients lose a lot of weight. So I usually assess it based on the patient's age, based on how much room they have to make adjustments to lose weight and how much time we have. Obviously we would love for everyone to be a normal BMI under 25 or under 30. I prefer if patients can get to BMIs under 40. I think most OBs feel very comfortable. What we have to know is that what we're talking about and what's best from a reproductive standpoint is sometimes then also needs to carry on to what's best for carrying a pregnancy, later down the road and monitoring a pregnancy and all those things. So I like BMIs under 40 if possible, but for any patient, a small reduction in BMI can make a difference. So, even my patients that are sitting at higher BMIs than that, sometimes we'll talk, can we lose 10 pounds? Can we lose 15 pounds? And will that make a difference for you? And if it will, that would be great.
I absolutely love your perspective. So you basically don't body shame patients and say, you can't get pregnant right now, I won't help you because of your size. You're basically going to work with them to see what they can achieve, if it's doable or not, but you'll still move forward with treatment, basically, is what you're saying.
Yeah, I will usually, in those patients that are on higher BMIs, we'll work with their OBGYN. We make sure that they have an OBGYN that's comfortable managing that pregnancy, because that's an important piece of the puzzle. But if their OBGYN is on board and I'm on board, we're just trying to make them get pregnant in the most healthy way possible.
Awesome. Well, Meredith, I loved having your perspective on this topic. It's been so fun having you today on the show. Can you just tell our listeners again where they can find you?
Yeah, sure. It's Indiana Fertility Institute, and I'm Dr. Meredith Provost, and I'm at Meredith Provost on Instagram.
Awesome.
MD, at Meredith
MD.
Provost, MD.
Okay. And then, just one last, parting sentence for our listeners. Like, if there's one thing that you can tell patients, or a patient who's sitting right in front of you, about fertility, what would you tell them right now?
Well, I guess that it's a marathon, not a race. You take it one step at a time, one day at a time, but just don't focus and get too locked down on taking everything out of your life. Just kind of take it one day at a time, be you. And if you haven't seen a doctor, come see someone, because it's not as scary as it seems.
I love it. So don't be too extreme with all the restrictions. That's a very good thing for people to know. Well, thank you again. Thank you for your wisdom.
Thank you.
I can't wait
Amy, it's
to
great
have
talking
you on
with you.
again. Have a great night, everybody. And I hope you guys
love
join us again for the next Egg Whisperer show. Thank you, Meredith. Bye-bye.
Thanks, Amy. Great
Bye.
being here. Bye-bye.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.